Good evening. For those of you that are just logging on, we're just going to sit tight for a minute or two and people join. I'm joined this evening by Dan Exeter, and we'll get going in about 60 seconds, so bear with us. So I think we'll make a start. My name's Mark Fulcher, and I'm from Access Sports Medicine. I'm joined by my colleague Dan Exeter this evening, who's also a sport and exercise physician from Access. Thank you for joining us. And your second, possibly your second webinar in a row. So we appreciate that that you want to come and join us and listen a little bit more about telehealth and prescribing in the current landscape. So tonight, Dan's going to talk a little bit about prescribing medication and pain relief, particularly as it relates to sports medicine and as it relates to the COVID-19 situation. So I'll hand over to Dan in a second, but I also want to just remind you about the other webinars that we're running this week. Tomorrow we have Steve Wood, who's the managing partner at Auckland Radiology Group, who's going to talk to us about prescribing imaging during the lockdown and the period afterwards. And then the day after, on Thursday evening, we've got Simon Grigger from Volum Marketing. Simon has a lot of experience in marketing small businesses. And, you know, obviously all of our practices have changed a lot over the past week. And talking about strategies to make sure that we still have people coming through the door and our businesses are well marketed and the patients know what we're offering. I think is critical for all of us. So I think that'll be a good session on Thursday. And then Friday, we're thinking about doing a wrap up of the week and trying to learn from you guys, as well as from our practice, about what's gone well in a week of telehealth in sports medicine and physiotherapy. So I think that could be quite a good practical session. That's on Friday lunchtime. And the other sessions are at 8 p.m. New Zealand time. So this evening we're going to run a slightly different format than we did yesterday. For those of you yesterday, Simon Young did a talk, which while I'm thinking about it is on Facebook. If you missed that and you want to see it, or your colleagues do, we're going to do a bit of a Q&A, if that's okay with you, Dan.
Fine by me, Mark. Sounds like a good plan.
Yep. And the other thing, just last night, some people had issues with the display and deciding whether they wanted to look at me, whether they wanted to look at Simon. So just remember at the top, you've got speaker view, you've got different options to look at things. The other thing is I'd direct you down the bottom. There's a Q&A button. If you want to ask questions to Dan or myself, make sure you type them there and we'll try and get Dan to answer them. So I guess we'll get going. Dan, why should we be worried about prescribing pain relief at the moment, and what sort of considerations should we be thinking about?
Mark, it's a good question. I think more than ever, we've got to be really judicious around the choice of analgesia we use. And there's two concerns around that. One is around some of the theoretical pharmacological challenges with some of the medications that are available to us. And the other is purely logistic, in that if you're thinking about asking someone to leave their bubble to go to the local pharmacy or get analgesia that they can't reliably get at the supermarket, you have to really think about making sure that that's going to be the right sort of analgesia for them, taking into account what their problem is, what some of their comorbidities might be, and those sort of factors which are particularly important. So I think it's a really important time to think about being as collaborative as we can around those sorts of discussions. And I'll just sort of give you an example. Normally in our consultations, when we're talking about analgesia, that might be a 1 or 2 minute discussion around a choice of a medication and what are some of the side effects and what are some of the things to look out for. But in the current climate, and we'll get to some of these specific points, my consultations, when we're talking about analgesia, that section might now go on for 5 or 6 minutes as we try to decide on, what is an appropriate approach to pain relief, given the fact that usually you've got to leave the house to get it, but also given what we know, or we think we might know about some of the analgesic options and their potential theoretical interactions with viral illnesses.
Okay, so you sort of alluded to that a little bit there. There's been a lot in the media about anti-inflammatory medications, so non-steroidal. So why might there be a problem for people who are worried about contracting COVID-19?
Look, I think the first thing to say, Mark, is that everything that I'm about to say now is very much theoretical. We don't really have any good quality evidence to say that any one anti-inflammatory medication increases the risk of susceptibility to COVID-19, nor does it increase the risk of an adverse outcome from COVID-19. But what people have been observing a little bit is that what seems to happen with the illness is that around the 5 to 7 day mark, there are a group of people who start to develop symptoms of what's called adult respiratory distress syndrome, or ARDS, which is a really powerful, almost pseudo-inflammatory response in the lung. And despite that being an inflammatory process, it seems that some of the anti-inflammatory medications may, and that's a very strong may, have a negative effect on some of the antibody production that needs to occur in around that time to help prevent that from happening. And the medication that has been implicated, and again, this is very weak data, it's not causal, it's just been observed, of the anti-inflammatory medications is ibuprofen. And one of the thoughts is that that might reduce some antibody production for individuals. Now, this has also been theorized to occur with paracetamol and possibly some of the other anti-inflammatory medications. And the data people are talking about is mainly out of cases of previous viral illnesses, not specific to this. But in a situation where we have analgesic options and we're trying to do everything to minimize the risk of this disease, then I think we still have some other choices that we can utilize that don't potentially increase risk at all.
Okay, so what are you advising your patients? So you talked about some other options. What's the conversation you're having with your patients?
Yeah, well, there's multiple things to work through, because at first you've still got to start with your basic considerations around, if we take anti-inflammatory medications, for example, around whether people have had gastric ulcers or whether they get reflux symptoms. And then also the sort of lesser known challenges with anti-inflammatory medications and their effect on the microvascular circulation and risk of cardiovascular and cerebrovascular events. And so generally, I'm generally a big prescriber of naproxen based on that sort of profile. And also it was therefore sort of pleasing to see that that wasn't specifically one of the anti-inflammatory medications that was theorized to have a potential to reduce some of the antibody production in the limited cases that have been put out there.
Okay, so that's the oral anti-inflammatories. Your anti-inflammatory of choice is naproxen. Are you still using other analgesics? Yeah,
so look, I think if you're thinking about where to start, and we sort of talked a little bit about the oral anti-inflammatories, but there remains a great role for the topical anti-inflammatory medications, and often you can get Voltaren gel and the like at the supermarket, so that's only one trip to somewhere outside your bubble to go and get that. And that remains a good option for joint-related problems that are close to the skin, or tendinopathies that are close to the skin, where you can get a reasonable dose of analgesia through the skin. And we don't think there's any adverse effects from that, apart from the ones that we already know, where sometimes people's skin can get a bit irritated. So that remains a sort of a baseline option before you start to think about oral medications. And then we tend to step up to those oral medications, and broadly speaking, we've got three. You've got paracetamol and paracetamol containing compounds. You've got your anti-inflammatory medications, and then you've got your steroidal anti-inflammatory medications like prednisone.
Okay, so like if we keep it really practical, I'm a patient who's had an acute knee injury. I've got a lot of pain. You're considering prescribing me anti-inflammatories. How are you counselling me about the potential risk with COVID-19 sitting in the background?
Look, I think the most important thing to say there, Mark, is that alluding to what I said before, is those elements of my consultation are taking a lot longer than they used to, because it's not merely because you have to create an informed consent environment. It's also because patients are reading widely about this and are coming with those questions, and so it's good to sort of cut that off at the pass. And that's why I'll go back to what I was saying before, which is that I think it's a really important time to be as collaborative as possible. So as many of you will know, we also prescribe exercise and rehabilitation, but we are increasingly sending that work out to the physiotherapy community who are practicing telehealth as well, because we're increasingly caught up with doing other parts of our consultation that may take longer than normal. And so what I'd be suggesting to people is it's a really good idea, if you're considering a patient who's in significant discomfort and they don't have anything really in the cupboard, so to speak, and they're not planning a trip to the supermarket and they're unsure where to go and you can't answer those questions, is to pick up a phone and give us a call, and we've got capacity to see these people to help prescribe analgesia and just to help them make as best informed choices we can, because a lot of what's out there is very, very theoretical, and it mainly needs people's fears allayed and helping them make those decisions.
Yeah, I think that's a good point, the need to be collaborative and to make sure that we're sharing the responsibility of these patients' care. So if we talk a little bit, there's also, I read that the NHS has effectively banned steroid injections within the health system in the UK. Do you think you could talk to that?
Yeah, that's interesting. I think what we need to remember about steroid injections is that whilst they're put into a joint, we know that people get a small body-wide dose of steroid from that injection. So it might go into a joint, but they get a systemic response from that. And that can last anywhere from 2 to 4 weeks, depending on which literature that you read. And some steroids may be less likely to do that than others. But I think the other thing to be mindful of is that in order to have a steroid injection, if it's done ultrasonographically, it means that someone has to be in close proximity to a sonographer for a reasonable period of time in order to be prepped and consented and prepared and have that done. And so you've got two situations there. You've got a medication that ends up in your system a bit and has a small immunosuppressive effect. And then you've also got a situation where you're potentially creating a close contact environment for a person who may or may not be exhibiting symptoms. And again, we are all learning here. I think a lot of these scenarios are sort of very theoretical, but I think it's actually really important, even though what we're talking about is potentially very low risk, to walk your patients through those steps, even if just to show that you've thought about them yourselves. And I think that's an area where we've found that extra time and perhaps sort of specific expertise has been required, because people are reading the stuff. It's all out there. It's easy to consume. And sometimes they just want their hand held through that process to understand around that. So in general, corticosteroid injections are something that we're looking to avoid at the moment. There are certain times where the benefits will outweigh the risks, but again, it's another scenario where it may be a chance to say, look, I think you need to have a chat to someone, walk you through it, and make those decisions in that way. It's a far more involved process thinking through that than it would have been before we were in these circumstances.
And I think a good point to make there, Dan, is that there are options. So a steroid injection is an option. You mentioned 3 different classes of medicines, but there are other ones as well. So I think, one of the things that I ask myself in this situation is, if someone had a bad outcome, how would I feel about the process that I went through what what was my role in that bad outcome? And so I think that the education piece in making an informed decision with the patient and clearly documenting it is important. We've had a couple of questions from the floor. So the first one is, if you think you've contracted COVID-19, could you just stop medications? And what length of time does it take for ibuprofen to come out of the system?
Yeah, good. Crikey, some good questions there. I'm going to dip into my pharmacology reserves here, but yep, you certainly could do if you thought that you'd contracted those symptoms. But bear in mind that many people have a window. Well, most people have a window where they're asymptomatic before they exhibit symptoms. As I said, it looks like potentially the key time is later on in the disease. But again, as Mark said, it's not potentially so much even about the real risks, because I think we don't have a huge amount of understanding about how these common medications really affect this specific illness. But it's about feeling that you've been able to take someone through the process of making that decision as best you can. So, yep, that's certainly an option. But I think, as Mark said, it really is about, have you been able to walk someone through that process.
The cases in France where this was first reported, the main concern was there were 4 cases of young people who had contracted COVID-19 who went on to have a very bad outcome. So I think the disease seems to be fast moving, and I think probably it's not as simple as saying you can stop the ibuprofen and prevent the bad outcome. I would imagine that the damage has already been done because of the ibuprofen use. So again, that's conjecture, that's uncertain. But I personally, reading the evidence and looking at the reports that we've had out of France, it seems unlikely that you could suddenly stop the anti-inflammatories and prevent the bad outcome.
Yeah, I think to answer the second part of that question, the answer is it depends. So if you look at the over-the-counter stuff, then the half-life is relatively short. It's in 3 to 4 hours. But some of the slower release preparations that people may be on, that half-life is a lot longer. And I think also it's remembering that people may be on those medications for other reasons. It's sometimes as risky to stop a medication as it is to start one. So we do need to be mindful of that.
So that leads me nicely to one of the other questions. The question is, what about Celebrex? And if patients are taking these regularly and getting good pain relief, would you advise them to stop? Or should they move to an alternative like naproxen?
Yeah, it's a great question as well. And I always feel worse when I do something and make someone worse, as opposed to do nothing and they carry on. I think we feel bad when we actively intervene and something goes badly. So I think if you've got a person who's got a good analgesic regime on a medication that works for them, noting that if you take all the COVID-19 stuff out of it, we know that people have quite individual responses to different anti-inflammatories. It's pretty risky to go fiddling around with that medication. There may be other key reasons, particularly why people are on some of the selective anti-inflammatory medications, and to just change them across to another one without having a thorough conversation with someone like myself or Mark or their general practitioner would be pretty risky. So I wouldn't do that in any case, actually, even in a non-COVID-19 world. And I guess the point at the moment is that these conversations that may ordinarily be happening with general practitioners, one of the things we're hoping to try to do is to keep, reduce some of the burden on general practice and A&E where, they're going to start to get quite busy, and the less the more well people we can keep out of those environments, the better.
Next question is, I think, more of a general discussion about anti-inflammatories. What would you prescribe non-steroidals for acute or chronic injuries that do not present with significant swelling?
I'm not sure if I can answer that in a short webinar. I think
they're good analgesics.
Sorry, Mark.
Uh, so I was just perhaps trying to steer you in saying that they are good analgesics independent of their anti-inflammatory effect.
Yeah, I guess that's sort of where I was going to go. And I think sometimes people get caught up in thinking, is there a inflammatory process at play, or is this a inflammatory problem? I think that the key thing to remember is that they are analgesics as well. And so most people don't like being in pain. And we know that pain in itself is not ideal from an immune system point of view either, particularly if it disturbs people's sleep. And so, yeah, I don't think you have to be too specific about saying, well, this sounds more inflammatory, this doesn't, when you're making some of those choices. I think there's far more other considerations when you're making your choices than trying to deduce what exactly is that process. If I could just use an example, a classic example is tendinopathy, where we've gone round and round in circles over the years saying that it's inflammatory, then it's not, then it is, then it sort of is, then it's quasi-inflammatory, then it might be inflammatory at certain times. But we all know full well that topical and oral anti-inflammatories can make quite a difference to people's tendinopathic pain at a whole variety of stages of the tendinopathic continuum. So sometimes we've just got to keep it practical.
Okay, so some good questions coming in now. So hopefully this one's a short one. Are you still recommending nerve membrane stabilizers at the moment?
Yes.
Good one. This one is more challenging for you, I think. So what are the medicines taken to treat the symptoms of the virus once it's contracted for high temperatures and body aches and pains?
Yeah, well, I think if we talk about just managing those sort of symptoms, and this is not advice about how to manage COVID-19, please. This is about what to do if you get a temperature. Then you start with simple paracetamol, and taken regularly, that's a really good way to help reduce fever. I think it's probably important to say in an environment where I'm talking to a group of people that if you're talking to a patient who describes symptoms of having a high fever and they sound unwell, then I wouldn't be making any advice around prescribing. I would be telling them to call Healthline or their general practice. So that's my party line on that. And I think it is important because we know that a lot of physiotherapists, patients will just mention that stuff to you. So again, that's sort of a time to pass that one on.
Yeah, look, I don't think we could stress that strongly enough. So I think in the current landscape, most patients would probably know to follow that up anyway. So next is, did you suggest that paracetamol should potentially be avoided, and what would you use first line for fever?
No, I didn't say that. What I said is that some of the theoretical, and I stress that, theoretical risks around some of the anti-inflammatory medications in terms of antibody number reduction have also been seen with paracetamol. And I can't stress enough what I've talked about tonight with respect to the effects of these medications on the immune system is very much in theory, and we have no good quality data to suggest that that these medications clearly lead to an adverse outcome for people with COVID-19. So I still think it's important that people treat these symptoms. It's anyone who's had a fever knows it's very uncomfortable, and I think paracetamol remains the first line. I think what you might not be aware of with respect to paracetamol is it's been traditionally prescribed at 2 tablets 4 times a day, and there is some concern that perhaps in some populations, some adult populations, that may be too large a dose. So again, some of these questions we'd normally see our patients having with their general practitioner, and this now may be an environment where perhaps we can play a role in assisting you with your patients when you're trying to reduce the burden on their local GP.
And next one is, I've heard prednisone is like a wonder drug for inflammation. When would you prescribe this, and are there concerns patients may become too dependent on them?
Yeah, good question. Prednisone can be a fantastic drug. much like many drugs if they're prescribed correctly. But yeah, prednisone can be a fantastic drug. Again, the answer to many of these questions is sort of, it depends, and the it depends is on the person, the circumstances, and the pathology. If we're speaking specifically in this environment, oral prednisone we know is definitely an immune suppressant. So it may not be the best option in some cases as a first-line medication. But again, there will be situations where it may play a role. And I think I've said may so many times in this webinar to really give you a sense of the fact that there is genuine uncertainty around these, and the decision-making process, the most important thing about the decision-making process is to help walk your patients through that. And that's not always an easy thing to do. If we're speaking about a non-COVID-19 world, then prednisone can be a great drug to really get people out of some sticky situations with pain, particularly radicular pain from cervical or lumbar discs.
Cool. So, yeah, I think that is a really important point. It's just there is no textbook answer here, and it's about, I think, using your judgment and expert opinion. So I'm going to put you on the spot, Dan. If you had a sore shoulder, which was bad enough to make your life a bit of a misery during the day, it was a little bit sore at night, and you're considering a steroid injection, would you have one?
Right now, no.
No. Okay. If you had severe pain in your back, in your leg, and you had extremely terrible sciatica, you were using a lot of medications, and you basically couldn't function, and you're offered a steroid injection, would you have one?
Yeah, I'd certainly consider it if I'd gone my way through the analgesic ladder, but I'd want to be walked through that decision-making process pretty carefully with someone who could answer my concerns and provide me with some rationale for what I was up to.
Okay. So hang on, here we go. Could you exemplify and tell a sentence you would use to inform a patient about the possible risks of COVID? So I think that's not so much about the medication, but more about the risks of COVID-19 itself.
I probably couldn't, more so than anyone else who's been reading around it. I think we're all relative novices to this disease. I just go back to the simple things we're being told all the time. That's what I'm saying to patients is that stay home, move out of your bubble when it's only when it's critical. And do try to get some exercise, but keep the physical distancing rules when you are exercising. So I feel pretty comfortable to speak about the role of exercise in this context, but I'm certainly no infectious disease specialist or epidemiologist.
Yeah, I mean, I think there are some key things that we should be sharing with our patients. First is that it's very infectious, and we should be worried about spreading it between people, as Dan's alluded to there. I think we should be, reassuring in some ways that most people who get this recover and they don't have a bad outcome. But we need to be very clear that some patients have a terrible outcome, and there are a number of fatalities that we're likely to see over the next weeks in New Zealand. So I think it's a viral illness. We need to be making sure that we're not passing this through the community. And I think for people that are maybe taking a fairly laissez-faire or relaxed approach to this, things are going to get worse. So I think that is a really important message to be sharing with our patients. And certainly in our family, my wife is a GP, we're doing our absolute best to stay away from anyone, even our next door neighbours. So I think it's a critically important message that we can all be passing through the community. There's a question, Dan, about on the analgesic ladder, where does opioid-based analgesics sit in this situation?
It sits right at the very top, and I think we have to probably reiterate that opioid analgesia, generally for musculoskeletal type pain, is something we should be looking to avoid. Now, that may be a little bit more challenging when some of our steroidal options are off the table. But I would struggle to remember the last time that I reached for a controlled drug script to write out for opioids. And I think one of the good things about New Zealand is that we generally don't seem to be big opioid prescribers. We're not seeing some of the issues that we see, particularly in the United States, around that. But generally, opioid medication for musculoskeletal pain is just generally doesn't have a major role. But in terms of an analgesic ladder, in the traditional ladder, it sits at the very top.
Okay, so there are two more questions here that both kind of link in together, and the summary is around, they talk about the mortalities in Spain, but I think they're talking about the mortalities in France, that found that there's a strong link between those that had died and those that had been taking ibuprofen. Are you aware of where these reports came from to back this up, or any available evidence?
Yeah, so they were 4 case reports, and that's why, as I've said all night, it's really important to that you all take what I say, not even with a grain of salt, but it's the evidence is very, very, very limited. So they were 4 case reports, people looking into why a group of 4 otherwise fit, healthy young people had a bad outcome. And then actually, as is often the want these days, it got picked up a little bit by social media, and then it ended up being some, I think it was some NHS recommendations, and next thing you know, people were being told to avoid these drugs at all cost. And that's not what I'm saying. What I'm saying is that in a world where things are uncertain and we have other options that may be equally efficacious, then when we've still got, whilst we may have very, very, very limited evidence and possibly no evidence, it's worth considering the analgesic choices just that little bit more carefully than you may have done a month or so ago.
And I think it's worth pointing out that those cases involve Nurofen or ibuprofen or Brufen, and there is some basic science data to say that maybe Brufen, more so than other anti-inflammatories, is more immunosuppressive. So if you are going to recommend these to your patients, and I guess based on what Dan's saying, probably you should think twice about that, that we should be absolutely staying away from ibuprofen and using other alternatives like diclofenac or naproxen or something else. Last question, well, maybe last question. I heard Dan say tricyclics were okay. Any other comments or recommendations for medical management of regional pain syndrome patients?
Yeah, that's a tough one, because in the early stages of that problem, prednisone can be fantastic. And look, the message really is the same, is that we've still got the same suite of drugs that we had a month ago, but informed consent is not just a thing you do. It's actually a process that you take people through. And so if you've got someone in severe pain, it may still be an appropriate drug for them when you consider all the other elements of their life and their other comorbidities and whatnot. The question is, how best do we help people make that decision and work through that process? It's not about saying a definite yes or a definite no. It's about saying, do I feel comfortable taking someone through what is a slightly more challenging discussion than it was a month ago? Or do I think someone else might be a better place to do that? And that will, free up my time to do other things for that patient.
Okay, I've got a couple of absolute beauties here. So thanks, Michael Heenan, for this one. Reflects the new reality of COVID-19. What would you do with a 70-year-old with spinal pain? Fair few grandmothers getting injured during children's washing this week. So a little bit to unpack there. 70-year-old spinal pain during the washing due to too many kids at home.
Well, it depends if it's somatic back pain versus radicular pain, but that's exactly, I don't want to sound like a shameless self-promoter, but that's exactly the sort of patient that needs their analgesic options discussed with a doctor, I think, because if they're not concerned about it and haven't read about it, then I guarantee their kids have, or their grandkids have, or their husband or wife has, or their next door neighbour has. And yeah, I think it just goes back to what I'm saying. All options are probably still on the table. It's just who is best placed to walk someone through that process and talk to them about the options.
But yeah, I think the key point there, anyone who's tried to order online groceries recently will know that those of you who are those who are over the age of 70 are a high risk group for getting a bad outcome with COVID-19. And if you're over the age of 70, you're much more likely to have a medical comorbidity and much more likely to be sensitive to different analgesics. So you need to be, that's a group you need to be really careful with your prescribing anyway. And then in the current landscape, even more careful. Next one is, as physiotherapists, can we recommend analgesics that don't need prescriptions?
Well, that's a question for you and your scope of practice, I think. And I don't think there's necessarily any clear need to feel that that has changed because of the situation that we're in. However, you have to ask yourself, do you feel you're comfortable to walk someone through the process? Do you feel it's the best use of your time in what's quite a challenging environment? I'm sure you're finding through telehealth where things are a little bit less efficient and perhaps don't run as smoothly. I think that if you're moving really beyond topical solutions or the very basic stuff that might come in a supermarket shop, in this environment, it's probably the time to pick up the phone and give us a call. Or as I said, ordinarily, you probably would have interacted with someone's general practitioner, but I think we're all very mindful that general practices and emergency departments need some respite, and I think we've all got a role to play there, keeping our sorts of patients out of those environments.
I think being mindful as well that even recommending that someone goes and purchases an over-the-counter prescription, over-the-counter medication, they're still considered prescribing the medication. So that's something to be mindful about too. Hang on, there's a few more coming. This sort of similar. Well, actually, they're both good questions. So the first one was, when would we refer to a specialist for analgesics versus the GP, even after COVID-19? And does this involve a referral or an email or phone call? The second one is a very good point. One of my concerns, and also, I guess, realities, are that GPs are struggling. So if we're referring to you guys and not to GPs, are we cutting them out of something they could be getting paid for? Mindful about them being busy and not wanting to take away their clients. So look, those are both really good points. And so we've been working really closely with some of the urgent care practices near us. We've been working very closely with some of the general practitioners around us. And they are quiet at the moment, but the message largely is that they don't want these types of patients in their practices. They're concerned about the possibility of spreading this illness, and they're also concerned about what might happen over the next few days and weeks if this does kick off. So the key message, I think, is send your patient somewhere they feel comfortable and they can access care. Some GPs have also gone for telehealth solutions, so you may be able to access that. But from our practice point of view, we are running some new acute clinics. So we have a doctor a day allocated to this type of thing. So if you're struggling and you need some help with pain relief, if you're struggling and you want to talk to someone about whether your patient should get an x-ray, we do have someone on deck to help with those queries. So the best way to do that is to either email us or to call us through our normal channels. And probably the easiest way from a medication point of view is just to have the patient have a conversation with one of the team. You can refer them, but equally we're happy to take non-referred patients during this period. So I would say that a purely analgesic conversation is probably something that the GPs are best placed to manage on an ongoing way. But right now, we're really trying to help our GP colleagues by picking up these patients so they don't have to sit in their waiting rooms. And I think what number do we call? So it's a good question. So the number I would call is it's an Auckland number, 521-9815. It'll come through directly to one of our PAs. If you have a look online on our website, there's some referral information on there. So the email and phone number there. And as I said, there should be plenty of scope to get an appointment on the day that you call. So look, that's been a little bit longer than I thought it might be, and it's more questions on what is kind of a slightly contentious topic. Maybe we're open to another question if someone has one. Oh, hang on, there's one more here. Struggling financially, yeah, I totally agree with you. So I think we're all struggling in the current landscape, and if you have GPs that you work with, and you have a good close working relationship, I would touch base with them personally. So how are they set up? So your patients will ask, do I have to go into the GP practice? So if they are offering telehealth or phone calls, that is an option. So I think just being aware of what's available in your community, and what I can tell you is the service that we offer, which is definitely we're able to see these patients. And then the last question I think for tonight is, can you please confirm you're happy to review non-sports injuries in older people? And the answer to that is absolutely. So our practice, it's sport and exercise medicine. The consultations that I find the most enjoyable often are the older patients. I saw a 99-year-old the other day who'd been retired since 1974. I asked him what he'd been doing. He said a lot of fishing and sailing. So look, I think it's probably a good place to wrap up. Thanks very much, Dan, for sharing your expertise and your opinions around analgesics. And thank you all for joining us. Remember, this will be posted on our Facebook page tomorrow. I think also on Physiotherapy New Zealand. And for those of you that were interested, there is also a webinar from yesterday with Simon Young talking about the assessment of the knee via telehealth. And tomorrow we've got a session with Steve Wood from Auckland Radiology Group. So same time, 8 o'clock. So look, hopefully that was useful to you, and we look forward to keeping working with you over the next 4 weeks and beyond. So thanks, Dan.
Thanks, guys. Stay safe and stay sane.
Good one. Evening, everyone.